Good afternoon, everybody. This is Marilyn Francis from the Patient-Centered Primary Care Collaborative. Thank you so much for joining us today for this presentation on choosing wisely in vulnerable populations. One note I wanted to make was that unfortunately Dr. Letourneau is not going to be able to join us today, but we have the wonderful Kelly Rand who will do the presentation for us. And so before we begin, just a little bit of housekeeping. The handouts are in the handout pane on the side of your screen. You can submit questions anytime by typing in the box, and we'll do a Q&A in the middle of the session and at the end. We'll do two of them. And if you do have a question, you can raise your hand to ask, and you will be unmuted. And also, if you need to adjust the size of the speaker panel in the slideshow, where it's points to number 4, there's a menu where you can make that adjustment. Next slide. And so after the webinar, please complete the post-webinar survey. Your feedback is always very welcomed. And we'll also be sending a recording and post the slides and additional materials to download on the pcpcc.org website /webinars. So just before we begin, I just wanted to give a little overview about the Patient-Centered Primary Care Collaborative. We have the mission to promote collaborative approaches to primary care improvement, which includes like patient-centered care, patient-family engagement, patient activation, and improved cost, quality, and experience outcomes. We're also part of the CMS TCPI initiative, Transforming Clinical Practice Initiative, where we are a support and alignment network. And also, I just wanted to have you note that we have many resources on our website. You can see where we can get them. And yes, I would encourage you to visit our website to look at these tools and resources that we have for patient-family engagement and quality improvement. So with that, let me introduce you to Kelly Rand, who's with the American Board of Internal Medicine Foundation, and she works with the Choosing Wisely program. And so, Kelly, you take it from here?
I sure can. Great. Thank you all for joining us today, and thank you for going along with this journey through Choosing Wisely that we've done with PCPCC. Before we finished all the webinars that we were doing with PCPCC, we really wanted to focus on an area that we've found to be important and that we're just starting to do research in. So today, we're going to share a little bit. We're not going to share, it's just going to be me because Lisa's not here, but I'm going to share a little bit about gaining understanding of what we've learned from safety net implementation so far, what tools we have that are available in this setting that we've sort of crowdsourced and put together for you, and I'm going to talk quite a bit about some of the focus groups we've done with low-income patients about how they feel about overuse. So just to give you a little bit of background on the information that we're presenting today, we started to understand how important implementing in the Choosing Wisely in the safety net was during our grant process. We had LA County as one of our grantees, and they're the second largest safety net health system in the country. And so we started to think, you know, we've seen Choosing Wisely in a lot of places. It's been implemented across the country, but a lot of the places that we saw implementing it were the sort of large multi-specialty institutions that you think of doing sort of leading care change. And we wondered if there was any difference in the safety net setting, particularly working with patients who had been historically had issues with access to care, whether there was an issue of overuse in that population, and whether reactions would be different to the idea that some care was unnecessary when in many cases those patients weren't getting enough care in general. So we did a fairly extensive literature review. We did the focus groups, which I'm going to really dig into at the end of this. And we also tried to have one-on-one key informant interviews with a number of folks that we knew that were implementing in the safety net setting. And that's where much of this work derives from. So the framework that we used to build our toolkit was when we were talking to sort of our key informants or our friends in the Choosing Wisely Learning Network, we tried to break it down into a way that people could digest it. So we've broken it into supporting effective patient messaging, engaging clinicians, and the actual changing care practices. Because we know people have differing interests in the level of this, the first thing you can see are 5 tips that you could consider. Then we have shorter resources, which last from maybe 10 minutes to 20 minutes in time to dive into. And then we go into some longer reports, hour webinars, and you can really guide yourself based on your interest in the topic. We have the Safety Net Toolkit on our website, and this just gives you an idea of where you can find it. It's under the Getting Started, called Implementation Toolkits, and it's the Reducing Low-Value Care in Vulnerable Populations. There is also a link in your handout. I'm sorry. So the first thing that we focused on was patient engagement, and I'm going to go over this fairly quickly because we're going to really get into it when we move into the focus groups. But we listened to what the safety net institutions who were working on this topic were saying, and what we heard from them is that they feel their patients want to be active participants in their healthcare, and that you can really build on your own practice by trusting your patients. So this is an idea that we've been talking about at the foundation in general, and there's a great article in JAMA that was written about trusting your patients. But it's not just getting the patients to trust clinicians, but trusting in their abilities to share what they have to bring to the table. Considering including crucial components of the Choosing Wisely conversations, like framing it as a positive. And we're going to go into some of the things that we really heard about how to frame a conversation about this later on. We heard overwhelmingly involve the whole care team so that people hear about the message from multiple people in multiple ways. Not only are you reinforcing a message so people are able to understand it more, but you're also having people of different power dynamics deliver that message. So there may be different people that they feel more comfortable having a conversation with or questioning, and it opens that conversation up to many people. It's an important thing to note that when you're thinking about incorporating the message through the different people in your care team, that you prep them with how to answer the questions or redirect the questions that they need to. Reinforcing those messages with posters, decision aids, and additional patient-centered materials. I think we've gone over a lot of that in some of our past ones, but using these pieces that have been tested with patients and are done at an appropriate health literacy level are really effective. And then partnering with organizations like your communications staff or community partners to help spread the message so that it's not just the patient hearing it several times within the point of care, but hearing it from the community. Clinician engagement also is an important part of this, and in much the same way that we want to think about how we frame this message to the patients, it's important to frame it with clinicians too. So you keep the focus on the clinician-patient conversation, focused on patient safety and improving care and the intrinsic values that most clinicians want to pursue. Make sure to make the recommendations and provide the data in a respectful and non-judgmental way. again, involving the care team, not just so that the patient hears it multiple times, but so that the burden of this message is within the full care team and not just on one provider. Be aware that most patients value time with a physician. So when people are thinking about the idea that patients come in just to get a test or treatment, many times patients come in to get information. So that it isn't like they're coming in and getting nothing. The visit with the doctor, the reassurance that they're okay, the ideas for ways to handle symptoms of things, these are all really valuable things that don't have to be quantified in something like a specific test or treatment. And then consider coupling conversations that focus on reducing low-value care with complementary messaging. So maybe someone comes in for antibiotics or asking for antibiotics because they have a cold. Consider talking to them about the flu vaccine if it's a cold and flu time. And then changing care in practice. And one of the things we did hear from a lot of our safety net friends was that while they are implementing, a lot of the literature out there is focused on how to do it in academic medical centers or places like that, and that it's a little bit of a different animal. So we put together this toolkit to help, and we're hoping to produce more to help in that arena. One of the most important things whenever you consider doing Choosing Wisely is thinking about really getting the bang for your buck. So we always recommend picking a test or treatment that occurs unnecessarily at least 40% of the time in your institution. Particularly to the safety net setting, we very much recommend the idea of balancing overuse with underuse. So when we've talked about how people want to implement it, instead of necessarily saying have a Choosing Wisely campaign on its own, we've suggested to do things that really focus on the idea of appropriate care. If you're looking at your patient's A1C to make sure that most of the appropriate patients have strict control, considering adding in a balancing measure to make sure that your older population isn't having too strict control that might cause falls or hypoglycemia. And thinking about how we look at the data and dovetail the idea of getting these overused tests in with ideas that will also increase the tests and treatments that some people have not gotten and need to get. Always use a multimodal intervention because reducing low-value care is a complicated objective, so multimodal seems to be much more effective. Making it the easy thing to do, so not only aligning it with projects that are already priorities so that it's not one extra thing, but integrating it into practice workflows, institutionalizing it where you can, changing order sets, making it the easy thing to do. And as we've talked about in several of our other webinars, really engaging the patient and family advisors in the planning and implementing of these improvement efforts. Because when you are talking about reducing care in some areas, you really have to be sensitive to people who have been marginalized from care in general. So I wanted to give a couple of the case studies that we either used by talking to people or we found in the literature. And the first one we have is the Veterans Affairs. So one of the Choosing Wisely recommendations is to increase advanced care planning, and particularly to do it in the ambulatory space before patients get into an acute situation where advanced care planning is a little bit more stressful. This has been shown to actually reduce a lot of unnecessary tests and treatments, and it also really is firmly based in that finding out what the preferences of patients are. So the Veterans Affairs used a multifaceted intervention where they put in physician reminders to have these conversations. they put chart reminders in the and flagged the charts that needed to have these conversations. They sent books about advanced care planning to people in their appointment, and a postcard that reminded the people to review the booklet. And then at their next appointment, they had the access to meet with a social worker to answer questions and potentially complete an advance directive. And it was really successful. So their advanced care planning discussions went up to 64% from 38%, and they included in their chart notes more often, and their living wills also went up from 23% to 48%. So even though they're pretty simple, it dealt with both sides, thinking about both how the providers do it and the patients do it. It had a lot of explanation based to it, but it was a multimodal approach. Simple multimodal, but multifaceted. Here's another interesting one about San Francisco. So we looked at this one as both a case study and in the literature. There's a great article that's been written about it. And it was an interesting technique that really focused on just the clinician side of it. So what they did was simply put into the electronic records a display of both the radiation exposure and the cost of imaging in the San Francisco Health Network. So when providers went to make their order, they saw both how much exposure their patient would get to radiation and what the cost of the test would be. And I think it's a great example that clinical decision support doesn't necessarily have to be just focused on, this is the indication. You're supposed to give it at this point. It's a sort of innovative way to really tap into that idea of physicians really being concerned about patient safety. And not surprisingly, with that patient safety lens on it, the safety information seemed to be the most influential part of it. But it was really pretty effective, where CTs declined by 15%, MRIs declined by 13%, and they reached out to the primary care clinicians who were using it, and they found that they liked the system. They found it really effective. It was information that they found really useful. And in it, they did report, again, that the safety information was more compelling than the cost information, though the cost information did change behavior. LA County was one of our grantees, so we were able to interview them, and they did two very terrific projects, one reducing inappropriate antibiotic prescribing for URIs, and one to look at pre-op testing. So they again use a multimodal intervention. They established new clinical guidelines. They changed workflows. They had physician champions. They did clinical education. They put commitment posters up in all of their sites so patients could see that this was a project that was important to them. And they had amazing reductions. They really reduced significantly their antibiotic prescribing, and they all but eliminated their inappropriate preoperative testing. Now, an interesting part of this one is that idea that I brought up of balancing measures. One of the things that they had done when they originally put it into play was to look at eliminating preoperative visits. And when they did that, they found that they had a significantly higher number of no-shows for the actual surgery. which is not good. But because they were thinking about what the consequences were, because they had put in balancing measures, they were able to really quickly reinstitute the preoperative visit. And then because they had eliminated so much of the unnecessary testing, they were able to spend that time answering patients' questions, really going over the instructions for what the patients needed to do for the surgery, and it was a really good patient clinician conversation meeting that improved patient communication, and then also went back to improving the rate of people showing up for the surgery. Our fourth case study is Cornerstone Health System, and again, a nice model of a multimodal intervention. They did clinical pathways in their electronic medical records. When they did the clinical pathways, they brought together multiple stakeholders within the health system to help create these pathways. So they were doing some political moves to get everybody on board with everything as well as it. They did peer-to-peer training. They changed their order set so everything was easier. And then once they put the practice into the order sets and had changed the clinical pathways, they provided feedback to their clinicians. And throughout the process, they also provided patient materials. And they were able to reduce their antibiotic prescribing for bronchitis by 33%, their reduction in DEXA scans for people of an inappropriate age by 45%, and their too frequent PAP tests by 76%. So we've seen that this, we don't necessarily have a special sauce on how to implement in the safety net. We know it's slightly different from a lot of the published pieces, so we've put together as much as we can of the knowledge. I hope you'll find our toolkit interesting. And before I delve into the messaging to vulnerable populations and kind of switch gears here, I just wanted to open it up for any questions anyone might have on implementation in the safety net setting or questions about the toolkit itself.
I don't have any questions right now.
Okay, well, know that you're welcome to put the questions in the chat, and we'll open the questions up again once we get through the messaging to vulnerable populations.
Wait a minute, we just got one question now.
Oh, sure, go ahead.
This is from D. Daly, and it says, over what time frame were you able to achieve the reduction as outlined in the case studies 2 and 3? And did you conduct a GEMBA, G-E-M-B-A, or observation period for all of these cases prior to implementing changes?
So, great questions. Both LA County and Cornerstone were over a 3-year period. And there was a 6-month period for baseline data collection for that. The San Francisco one and the Veterans Affairs ones were both ones that we got from the literature. I believe the San Francisco one went on for over a year, and I don't know what their baseline collection looked like. And I apologize, I don't remember the dates on the Veterans Affairs, but again, it was a pretty significant time period. To be honest, for most of what we have seen in implementation for reducing overuse, it tends to take a little bit longer than your regular QI project. If in ideal situations, maybe 6 to 8 months, but for some of the ones that have a high patient demand, it can often take over a year to start seeing results. But I'm also happy to send to Marilyn the articles that we used as reference, or those articles are referenced in the toolkit that is available online.
Okay. All right, and we have another question from Michael Wilson. Is there a way to find out geographically where Choosing Wisely has been implemented by state?
That's a great question. You can email me. We do an environmental scan of people who are implementing Choosing Wisely. It is not 100% inclusive, but we have pretty good coverage of people we know who are doing it. There are not a tremendous number of statewide projects. Maybe 9 or 10 states have tried to do a large region or the full state. But if you email me at krand@abim.org, I'm happy to connect you with anyone we know that's working in your state.
Okay. All right. We don't have any other questions right now. So.
Okay, great. Thank you. So my background is medical anthropology, and one of the things I thought was really important when we started looking into this was really to get a better understanding of what patients were thinking about Choosing Wisely. We've been extraordinarily lucky through the Choosing Wisely campaign to have Consumer Reports as a partner for the first 5 years. And while Consumer Reports was very rigorous in having the materials reviewed, a lot of the information we received about the campaign in general was reactions from their base, which tends to be whiter and richer. So we really wanted to do some intensive work in communities that might not have heard about the Choosing Wisely message and might have different reactions to it. So we decided to do 4 focus groups. Because we knew that 4 focus groups was not a huge amount of people, we really thought it was important to do a community participatory approach. And I think it made all the difference in what we did. So we did 4 focus groups. We worked with about 33 participants. We oversampled for African American and Latino participants. We also oversampled for participants that would either have young children or be caring for older adults as part of their family. All of the people that we interviewed were at 250% of the poverty level or below. And we really wanted people who were engaging in the healthcare system. So we asked that people have had at least 4 interactions with the healthcare system within the year. And when we did this, as I mentioned, we worked really closely with several community groups in both of the places that we did it. So as we developed the guide to talk about or what our focus groups would talk about, we had them sit in with us in the focus group facility to observe it. We then took their opinions when we at the end of the focus groups, we got their ideas. Then when we made the report, we had them give more feedback about the implications of what we thought we heard. And I think it made it a much more robust process. Overall, a lot of the messages of Choosing Wisely really resonated with underserved patients. Some medical care is ineffective and unnecessary. Some common prescriptions and procedures and tests are overused and should be questioned. Patients and physicians should be having conversations. regardless of the patient's income, insurance status, ethnicity, and other factors, his or her opinion must be part of the medical decision-making. And I think as we get into this, one of the things that we heard is that there is a lot of implicit contradictions in how participants replied, which I think shows how much our healthcare system is in transition, but provides initial insights into some of the barriers and motivators for what will make these conversations work. So one of the things we saw that was a distinct difference from conversations that we've had over the last, say, 15 years is that participants said they were really willing to challenge their doctors about care decisions. We know that the ACA has been pushing patients to be more consumer-oriented, whether that's good or bad. There does seem to be like a significant shift from previous focus groups where patients said, I heard what my doctor said and I did it because that's the roles that we take. Participants really felt like they had a say in what would happen in their body. So I pulled a few of the quotes, and I'll just read a couple of them. Some I'll let you read. But if the doctor says do X, Y, and Z, and you're not sure about that, what do? Well, I'll question it first. If you give me a good enough reason, I'll say, sure, let's do it. But if not, I'm not going to do that. In almost a contrast to that, participants expressed relatively low levels of trust in their providers. While you may think that having more engaged conversations of questioning was a sign of higher trust, many of the participants we talked to were very conflicted about what the motivations of both the health system and the providers that they were going to. I should also specify here that almost 60% of the participants we spoke to sought their care from either urgent care, with a small fraction of that being from the EDs. Patients who were in long-term care relationships with a primary care provider did tend to express more trust in their physician. But I would say that the vast majority we spoke to either sought from urgent care, or they went to a place where the providers changed very frequently, or they could not find a relationship with a provider that they felt was comfortable, so they chose to change providers. And so this low level of trust makes that choosing wisely conversation a little bit more difficult. Participants also said that they researched their own treatment options and they trust their own judgment. So we think this is an important thing to think about when having the conversation with the patient, because if they do trust their own judgment, then one of the roles I think the health system may have to take on is how do we help patients understand their health needs. Again, this is really deeply embedded in the shared decision-making and how to provide good decision support for patients. Many of the patients were very well educated on some parts of things. So we had a gentleman that was just out of, he was on his last day of parole. He had been had marginal housing in the past, and he had, he didn't have a significant educational background. And when we asked him about, how do you make decisions about the prescriptions you may or may not take, he said, well, I always go to the pill book and I check out what the side effects are and I look at the indications, like very sophisticated, intelligent answers. But from the same standpoint, this group of people also had fears for vaccines. didn't really question natural vitamins or natural remedies or homeopathic remedies. So I think there is a lot of information. I don't think this is new to most of you. There's a lot of information out there, and how we have conversations to help patients understand what information they can use to research things that has an evidence base and is substantial and gives good advice, versus things that don't have that same evidence base, is in a really important area for us to think about, and how we help self-correct some of the misinformation out there. More than anything else, we heard low-income patients wanted to be heard by their healthcare system and by their clinicians. Overall, we had people thanking us for even having the focus groups where they got to talk about their health. And I think one of the most interesting stories was when I shared this focus group information with one of the health systems that we interviewed as part of the key informant interviews. They said, we see how that is a problem. We recently implemented a new translation service, and within that translation service, we did a whole thing with all of our clinicians. We said, how is this translation service working? Is it, are you getting the answers you need? Is it effective? Is it easy to use? And all of the clinicians overall pretty much said, this is great. This is so much better than our last service. We're getting everything we need. It's working flawlessly. It's terrific. Being responsible health system, they also surveyed their patients. And their patients said, no, this translation service is terrible. It gives all the information that the doctor wants, but it doesn't translate anything that I want to talk about. It doesn't translate any of the things that I think are important. So I think it's a great illustration of people can have conversations, but framing the conversation in a way that the patient's preferences and the patient's ideas of what's important in the conversation come through is a really important thing to think about in all patients, but particularly in patients where there's a historical distrust, there's a very current distrust, and the idea that care has been, it could be being both underused and overused in a group of population that could be more heavily affected by both those factors. It's a really important thing to think about. So one of the things that we came up with the focus groups was the conversation framing. And it's a pretty simple framing that they said they would respond to. First, they wanted to be listened to, and they wanted an acknowledgement that the person had heard them. Again, we heard about framing it as a positive, which I mentioned in the toolkit. So thinking about it from the standpoint of, it's really good news that you don't have an infection. An infection can lead to worse things. So it's great that it's just a cold. Let's talk about ways to help those symptoms that you have that are keeping you down, but good news that it's not an infection. Providing a clear rationale that includes potential harm. So if a patient requests something, giving them an understanding of what your care plan is going to be, why you may or may not choose what they've asked for. So say a patient asks for antibiotics, saying, you don't have symptoms of an infection, you haven't had a fever, you've had these symptoms for less than 6 days. I really think it's just a cold, and we're going to do these things to help you feel better, but I don't want to give you antibiotics because antibiotics can, have side effects that could be potentially uncomfortable, and also we want to save antibiotics for when you really need them. But also giving your plan B and C. If after 10 days you're still not feeling well, if you start to feel better and then get worse. If you develop a fever, if you develop some other signs of infections, and these are things I want you to look at, we will consider antibiotics. Or if it's not within your plan, why you wouldn't consider the thing that they've requested. More than any other group, this group wants to know that the reasons you're making these choices have nothing to do with their insurance status or their status in society, that it's not rationing, that it is a care plan that's based on their needs and on their safety. And then finally communicating that care plan and next steps in a clear way that may also have some sort of reminder or printed material or sent material that helps them know and understand and look back at it. We heard from some of the participants that they believe their clinicians displayed bias. Many of them saying that they felt that bias was based on their insurance status. Most clinicians, I don't think, necessarily know what a patient's insurance status is, but this is something to consider when you're talking about the conversation. So perceived bias is still going to affect your conversation. It's also something to think about from a systematic standpoint of making sure that you don't do anything that would group people together in a way that could affect these things. So just things to consider when you're going forward. One of the things that we thought was probably most important was that patients recognized and had experienced the harms of overuse. So while literature certainly shows that overuse is just as regular in vulnerable populations and as it is in any healthcare setting, we did go into this somewhat concerned, again, because people who had been marginalized from care may feel less comfortable with any care being withheld from them. But many of the patients had not only recognized the idea that there could be overtreatment or over-testing, but had stories of harm that had happened from it. So it was something that resonated pretty easily with this group. There was a distinct difference, though, in how they viewed procedures, prescriptions, and tests. So for the most part, procedures seemed to patients to cause the most unintended harm. So that harm case is probably the easiest one to have on procedures with patients. Prescriptions came a close second. And then tests were a muddier topic. So many people did not necessarily see the harm in having tests. They thought, well, tests just give more information to my clinicians. So I think that those probably require a little bit more intense conversation and probably a lot more scaffolding around patient education and community education about the risks of it. Participants expressed the want that the health system should recognize their individual needs as a patient, and I think that's pretty much what we've been talking about in this series in general with PCPCC, the idea of really bounding things and shared decision-making, including patients into the process, really including the patient voice, which is not only effective in helping improve health outcomes, but very directly what the patients we talked to asked for. I didn't read all of the quotes, but I think this one is one of the most meaningful ones that I pulled out of listening to the conversations. Having a conversation, to me, it lets you know we're going to go back and forth about this. It's not like an argument. Dialogue between you and your doctor. You guys are finding out what's the best way to treat your illness. they're not just talking at you, they're talking with you, and they're listening, and you're listening, and you're working together rather than just, this is what you've got, here you go, here are some pills, and telling you what to do. We really distinctly heard from actually both patients and the key informant interviews that we had that these conversations are not necessarily the easiest ones to get started, but that they make the work so much more rewarding, and that they make the outcomes so much better. So we're going to continue to do research in this area, and I understand it's hard to think about how we incorporate the time. But from what we've heard from both the patients and the clinicians who are doing these types of conversations, it is a radical change in treatment, and it changes the dynamics between the provider and the patient. It changes the outcomes for the patient, and it can potentially change the joy in practice for the provider. And again, we couldn't have done any of this without the support of Robert Wood Johnson, who funded the focus groups. The focus group opinions we expressed are not necessarily those of Robert Wood Johnson Foundation. McCabe Message Partners was our communications partner in putting together these focus groups. And again, I can't speak enough to the value of adding community partners in helping us build these conversations and then also analyze the conversations to make them much richer and more robust and have more perspective and understanding of how to do it. It took a small sample and made really rich results because we were able to add the voices of the community and people working in the community. So thank you, and I'm happy to answer any questions.
All right, let me see if there's any questions here.
I will say, while anybody's asking a question, we have written a white paper on the results of our focus group, which we will be planning on releasing on our website either later this month or next month.
Okay. Doesn't look like we have any further questions. Please feel free to raise your hand or type in a question if you have one. Okay. Looks like there's no more. So thank you very much. Thank you, Kelly, for a really wonderful presentation. I really hope that everybody comes away with a little bit different perspective and listening to the patient voice. So thank you very much. And again, my name is Marilyn Francis at the Patient-Centered Primary Care Collaborative. And you're also welcome to reach out to me if you have any questions. Thank you.
Thank you, Marilyn.